Let's go ahead and discuss allergic disorders. This is the nursing assessment and management of. Today, the objectives we're going to go over are listed below. You can go ahead and press pause and read through those on your own. You're going to want to know the difference between active immunity and passive immunity. And I'm going to bring in the immunizations into this slide as well. So for active immunity, this is when the body is producing its own antibodies. Passive is when the antibodies are received from an external source. So let's not get confused though here. So a vaccine is actually not considered passive immunity because it does not involve the transfer of pre-made antibodies, from an external source. So instead, a vaccine actually introduces an antigen, It's a harmless part, though, of a pathogen, and we're having that inserted into the body. And that's going to stimulate the immune system to produce its own antibodies and develop the immune memory, basically. All right, that's the process that is considered active immunity. All right, so in contrast, passive, it's more involving directly received ready-made antibodies. This could be something like through maternal transfer, so from the mom to the baby. So that would be through like the breast milk, okay? Let's see if I can give you some other examples. So active immunity could be not only getting a vaccine like the flu shot, but it could be recovering from some sort of infection like the chicken pox, all right? Whereas passive immunity, the antibodies are passed from the mom to the baby through breast milk, all right? Or it could be receiving actual antibody injections, for instance, like the rabies immunoglobulin. Here's a few terms that you want to be aware of when it comes to allergies. So we have an allergic reaction. That's an inappropriate immune response to harmless substances, and it's triggered by the immunologic mechanisms often involving IgE antibodies. We have allergen examples then. So an actual allergen are things like peanuts, tree nuts, dairy, soy, gluten, egg, fish, shellfish, etc. So there's quite a number of things that could be considered an allergen. And then we have those immunoglobulins. So we have several different ones there. The ones we're going to pay attention today mainly are with the allergies. So that's going to be the IgE. So these are antibodies produced by lymphocytes and plasma cells. So in terms of allergic reactions, like I said, we're going to think about the IgE. That is binding to the different allergens, and it's activating those mast cells. And in return, it's releasing chemical mediators like histamine. So what happens when we have histamines releasing? Then we have things like inflammation. We could have other responses such as respiratory symptoms like sneezing, congestion, runny nose. They could have their nose or throat getting very itchy. If they start coughing and wheezing, that means their throat could be closing up and they get very short of breath. They could have eye symptoms such as itchy, watery eyes. Their eyes could get really red. And then the skin symptoms could be things like hives and other rashes. They could have itching, they could have swelling, all of the skin. If it got really bad, it could be the severe reactions of anaphylaxis, which goes into with that respiratory where they get very short of breath because that airway is starting to constrict because it's swelling, that histamine's releasing, and that tongue and throat is swelling. So again, you'll see difficulty breathing. We're going to start seeing possibly getting blue around the lips, very pale, flushed skin possibly, rapid or weak pulse, depending on what's going on with the patient. So as an example, if a child has an IgE-mediated allergy to, let's say, the protein in milk, they may experience symptoms in the skin, such as hives. They could also have GI upset, so they could be vomiting or have really bad nausea. They could be coughing or wheezing, so that brings the lungs in play. And they could have circulatory system issues, such as their blood pressure could actually be decreasing. Okay, you're going to have to think back to pathophysiology a little bit. I went ahead and put the WBC differential down here on the left. These are the 5 WBCs that make up the 100% of WBC circulating in our blood. right? The normal WBC count that you would be seeing is 4,500 to 11,000. And then the 5 different WBCs would be neutrophils, which make up about up to 70% of our WBCs. And this is our first responder to infection, especially bacterial infection. Then we have the lymphocytes, which can make 20 to 40%. This is our key player in immune responses. This is when our T cells and our B cells are jumping in. Then we have our monocytes, which is way less. It's about 2 to 8% of our total white blood cell count. And this is helping remove debris and fight chronic infections. Then we have even the eosinophils, which is only about 1 to 4%. This is also inactive in allergic reactions and parasitic infections. And then lastly, we have the basophils, which is the smallest of the white blood cells, only making up about 0.5 to 1%. And this is when we're having the histamine released during allergic responses. So make sure that you kind of brush up on that piece. I put some up here in the far right for you as well, just to give you a nice little visual. These terms in here though, leukopenia, leukocytosis, neutropenia, and what is called a left shift. Let's dive into those. I need you to know those for this class. So with leukopenia, that's when our white blood cell count, so the total white blood cell count is getting less than 4,000. So this could indicate things like drug toxicity, autoimmune disease, even bone marrow failure. One big thing is if they have a very overwhelming infection, we could actually see that white count less than 4,000, okay? We also then have leukocytosis, is when the white count is going above or greater than 10,000. You're going to be seeing this, which also indicates severe inflammation or infection, trauma, stress. This is more likely something that you're going to see when your patients are coming in and they have some sort of acute disease process going on, some sort of acute infection. We're probably going to see that white count starting to go up. And our hope is that we see that come back down to a normal range. Then we have neutropenia, neutrophil count, all right? So that should be normally less than about, it's going to be about less than 2,000, and that could indicate in viral infection or bacterial infection. So we really keep an eye on this neutrophil count for those, especially who are undergoing things like chemo, radiation, or have any type of immune deficiency. Less than 1,000 on that neutrophil count is meaning they should definitely be on something called neutropenia precautions. And that's when we're making sure that if somebody delivers beautiful flowers, we're actually not having them put in the room. We kindly let them know, hey, patient is on these certain precautions, and the flowers, although very beautiful, we're going to go ahead and let that beauty be up at the nurse's station so everybody can see it for now until the patient can have those flowers in their room. Okay? Don't ever make anybody feel bad about having those flowers that they brought. Sometimes people just don't realize that they could potentially do a lot of harm to the patient. The last thing is that left shift, and this is simply that it's an increase in the immature neutrophils, and that can occur with an acute infection. And it goes back in the history of why they call it a left shift. It had to do more of what it looked like on the paper when they were printing everything out. It showed a left shift in those immature neutrophils. Let's dig in to the allergic reaction steps at the cellular level as well. Again, thinking back to pathophysiology. So we have our first exposure, which would be the sensitization, and that is in the top left picture. So as an example, let's say you have a flower and you're sniffing that flower for the first time, and your immune system mistakenly thinks that the flower's pollen is dangerous. And we all know normally it's not something that would be dangerous, but for some people, their immune system starts attacking them, and they may think that pollen, that allergen, is dangerous. So what happens is our T cells recognize that the pollen is a threat, and it tells our B cells to make that IgE antibody against it. And that is when those IgE antibodies attach to the mast cells, which are, of course, our immune cells in our body. And they really attach near that nose, skin, and lung area. The mast cells are now trying to really get armed and ready to react any other time that that person goes and tries to smell the flower and encounters the pollen. So let's say then, second time around, patient's smelling that flower again, okay? The pollen begins to enter the body. The allergen, the pollen, of course, binds to that IgE antibody on the surface of the mast cells, and it's activating them. And at this point, that's when we really could have that chemical release and inflammation. That's when we're seeing the histamine released. All right, and remember, the histamine is causing that inflammation, leading to things like a runny nose, itchy eyes, sneezing, swelling. All right, and that is when we are then having those allergic symptoms, which is, of course, the inflammation. Again, that's triggered by those mast cells, and it's causing those visible symptoms like the sneezing, watery eyes, and stuffy nose. And these are all your body's overreaction to the flower's pollen, which could normally be harmless for most people. Breaking down those B and T cells a smidge more for those of you who need that. The B cells, think of them like the security cameras. So they are detecting the intruders. In this case would be the antigens. And they're sending out an alarm, or the antibodies, to neutralize the threat. Okay, they're producing the specific antibodies to fight infections by creating the plasma cells, which release large amounts of antibodies. Whereas our T cells, they are more like the security guards. They are responding to the alarm. They are directly confronting the intruders. And that's why they call them the killer T cells. They're helping coordinate the response by calling for backup. They help the B cells. They destroy harmful cells, and they activate macrophages to clean up debris and digest antigens. Okay, now that we got that out of the way, let's move on to the allergic hypersensitivities. There are 4 types. Type 1 is the anaphylactic or immediate response. This can happen from the allergies, and we can have the anaphylaxis, okay? Type 2 would be considered cytotoxic. This is antibody mediated. This is an example of this would be getting the wrong blood transfusion. Type 3 is considered the immune complex mediated, and this would be from diseases such as lupus or rheumatoid arthritis. And then type 4 is our delayed. Delayed meaning once they're introduced to it, it could take 24 to 48 hours, sometimes longer, for the patient to have any signs, symptoms show up. And so things like this could be poison ivy or a TB skin test. So let me see if there was anything else I really want to tell you about this. The type 1 hypersensitivity is the most severe. So remember, when we're having this anaphylaxis, it's immediate. We could have edema in the tissues, and we can have bronchospasms. We can actually have things start to close up, all right? And worst case scenario, we have cardiovascular collapse, and that would be in very severe cases. Type 2 hypersensitivity, again, that occurs when those antibodies are directed against antigens on cells. And then type 3, that's damaging the inflammatory reaction caused by the insoluble, meaning it can't be dissolved, immune complexes formed by antigens that bind to antibodies. So an example, again, would be something like RA or lupus. And then the delayed, as I said, it can take 24 to 48 hours, sometimes longer. That's why with TB, when you have, we have to make sure that we're waiting a certain amount of time to have the skin test read. All right, there are 2 types of the IgE-mediated type 1 allergic reactions. So they could be atopic or non-atopic. So the atopic is a genetic or familial link. So that could be things like asthma or eczema. And then the other one is there's no genetic link. And that could be something like an allergy to things like latex. All right, moving on to allergic rhinitis, or what is called hay fever. So this is an inflammation of those nasal passages, again caused by allergens. So when someone is sniffing that flower and getting the pollen, the inflammation can happen right then and there, all right? The different types, they could be seasonal, so triggered by things like the pollen during specific seasons. They could also be perennial, meaning year-round due to indoor allergens. Those of you who have indoor and outdoor allergens happening to you, you know how devastating that can be to your day-to-day life. So causes and risk factors. We have, again, the pollen, dust mites, mold, pet dander. So if you ever have your basement flood or you move into a really old house, you should have it tested for mold before you move into it. If your kids are having a lot of asthma issues or a lot of allergy issues, again, good to have things tested for the mold and perhaps have deep cleaning happening in your ducts or whatever may need to happen, especially in those older homes. So again, risk factors, family history of allergies, asthma, or even eczema. And those symptoms are going to be similar, just like we had talked about, the sneezing, nasal congestion. They could have a runny nose, nasal itching, postnasal drip, and possibly a cough in some cases. For nursing interventions, so we're going to have to assess our patient well. As you think back to health assessment class, and we really pushed doing a really thorough health history. The more questions you ask, the more you dig, the better and more thorough assessment findings you have. So we want to know the subjective data, such as the history of their symptoms, what the triggers are, and when the timing of this is. We want to have objective data. We want to know what is going on. Are we seeing that there's swollen nasal passages? Are they having any nasal discharge? We also want to do some diagnostic tests. We may have to do that skin prick test or a serum IgE testing. So that IgE testing, we draw the blood. The skin prick test, we will discuss that more in class. For nursing interventions, you want to educate your patient, okay? You want to avoid the allergens. So we may need to have air purifiers. They may have to stay indoors more during the high pollen seasons, and they should be using their medications the proper way. Don't just ask them, do you know how to use your medication the proper way? You should actually watch them do their nasal sprays and their any type of antihistamines. Then symptom management, they may even want to do a saline nasal irrigation for some relief if they're very congested, and they need to adhere to the prescribed treatments. So things that they could take, some antihistamines, that's going to help relieve the sneezing, itching, and runny nose. They may have to do an intranasal corticosteroid to reduce inflammation and congestion. They may have decongestants. That should be more of a short-term thing. And they also may have a leukotriene receptor antagonist, and that's for patients that have asthma. And we'll talk about that more in class when, especially here in Missouri, if you have allergies and you have asthma, those are two recipes that could be disastrous. So when you have a patient that comes in and they are then currently having issues with allergies, you want to make sure, of course, they're not in distress. We're going to do it besides that health history and asking them about the symptoms they're having. We are going to be looking for the different signs. What do their eyes look like? Are they are they swelling? Are they red? And then we can ask them, of course, if they're itchy or burning. Do we see any discharge? For their nose, are they currently sneezing? Do they have a runny nose? What color is the drainage coming out? When we are looking up inside the nose, are we seeing that it's very swollen? Are they currently congested just as they're sitting there in front of you? Looking at their throat and chest, are they struggling to breathe? We've talked about that before. We really want to make sure that we are checking their vital signs. Look inside their mouth. Look at their throat. Is it red? Are they wheezing? Are they coughing? And then looking at their skin, do they currently have any rashes or eczema or hives possibly? Are they currently scratching at their skin? And then triggers, of course, you all have done that family history, find out what medications they're on, find out if they have any irritants such as perfumes, are they smokers, what's the weather like right now, etc. And what's the time of year, day, night, hot, cold, what have they been eating? Are there specific rooms that triggers things for them? And then we jump into the diagnostic test. we may go ahead and do a CBC, that complete blood count, to check for that white count and that eosinophil count. The IgE levels, it could be very elevated in allergic diseases. We would want to do the skin test, which is that prick test. There may be a scratch test or an intradermal test, depending on what we're trying to see what's going on with the patient. And then something called the RAST test, the RAS test. That's a blood test to determine the sensitivity to various allergens, specifically that IgE is elevated. Okay, a little bit more on the anaphylaxis. So if someone comes in and they are in respiratory distress, we have to act quickly. Those symptoms appear suddenly and they worsen over minutes to hours. Common symptoms, they're very flushed. They could have the hives. They have swelling, angioedema, so swelling on their face. They have the low blood pressure. They could have breathing difficulty because of the bronchoconstriction. Again, common causes. We've talked a lot about different cases, but we also have to think about the medications. Are they on any antibiotics, especially penicillin? Treatment. We want to make sure we're getting them the CPR if needed, get them oxygen if needed, intubate, get ready for that if needed. And we're going to be getting ready to administer epinephrine. All right, that is we'll be doing that subcutaneously. If they have an EpiPen, we're going to learn about that in class on how to administer that. And we will most likely, if in the hospital, be using IV fluids for support. This ends this brief session. What you learned today is right below. Make sure that you read through that and you go back and study anything that you need further clarification on. We will also go over it in class.